Greetings, everybody. I want to thank Dental XP for giving me the opportunity to do this webinar. And our subject is implant overdentures, what you need to know. Quickly, just some disclosure. I am in full-time private practice. I am a periodontist. I do multiple implant systems, and I'm not under any contracts, nor do I have grants from any commercial entity. I do from time to time receive sponsorship for giving a seminar. I'm not receiving any sponsorship for this particular seminar. Here is the basic outline of what I'd like to cover today in our webinar topic. And I think we need to really start off with some definitions. I show here a picture of some mini implants next to the word two-piece implant because most people think of one-piece implants where we have an implant that has an implant and abutment that are fabricated as a single unit. Often people think of that as synonymous as mini implants, but the lines are being blurred because, as you see in this slide, we have mini implants that are actually two-piece implants today, and conversely, we have wider diameter implants, as you see on the bottom part of the screen, that are one-piece implants. So we'll primarily be talking about two-piece implants today, where we have a separate attachment to connect to the prosthesis. But again, we should be clear on what a one-piece implant means and what a two-piece implant means. Similarly, from a surgical one-stage procedure versus a surgical two-stage procedure, the one stage is where the implant is placed where it is already exposed to the oral cavity. It could be through the design of the implant itself, or it could be through adding a transmucosal healing component at the time the implant is placed. Whereas a two-stage surgical procedure is where the implant is purposely submerged under the gingival tissue and is uncovered at a second stage later on. Again, continuing on with some definitions, an immediate implant from the surgical point of view refers to the placement of the implant at the same time that the teeth are removed, whereas immediate restoration, which may not be loaded, it's not necessarily the same as immediate loading, refers to the placement of a restoration at the time that the implant is placed. Implant retained, which relates more to our topic for today, especially as we look at the full arch fixed restorations versus full arch removable restorations. So implant retained means that the implants provide retention for the prosthesis, but do not really support the load. There's usually some soft tissue support when the prosthesis is under load. Whereas implant supported indicates that the implants are primarily the source for support for forces applied to the prosthesis, such as a full arch fixed prosthesis, or it could be a full arch bar prosthesis, for example. So let's look at some case types. Let's first look at an overview of different case types, and then we'll be delving into more detail. And again, when we're going to look at overdentures for starters, again, we could be considering one-piece implants, and most often those are the mini implants, but not always, so usually less than 3 millimeters. Or we could be more often looking at using a two-piece implant design, and typically those are 3.75 or wider. Once again, with two-piece implants, you have different implant designs, some designed for a submerged protocol, some designed for a one-stage protocol, and we'll look at those too. So let's start off with our two-piece implants, which are the workhorse, at least for my practice, when we do overdentures. And now we want to know, should the implant design be a two-stage design, where the prosthetic platform is placed subgingivally and it is more easily submerged? Or should we be looking at a one-stage design? So this is an example of a two-stage implant. It's the screw vent design from Zimmer with an internal hex connection, and it is designed to be placed subgingivally, can be used for aesthetic type cases, and could be used for an overdenture type case, but you don't really have to have the implant submerged below the tissue for an overdenture, because any exposed metal would be covered up in the prosthesis. So you could make your life easier by utilizing a one-stage type of implant design. where the prosthetic platform can be positioned close or even above the gingiva, such as this implant here. This one happens to be an MIS Mistral design that looks quite similar to a tissue level Straumann implant, at least in the prosthetic table. It's pretty much the same. And these implants, that smooth part is designed to be placed above the bone at the time of surgery. And you clinically, once it heals, you're looking at the prosthetic table, in this case being slightly supragingival. And that's the implant you're looking at, not the actual abutment. So for overdentures, you can facilitate your prosthetic procedures by not having to work with subgingival prosthetic platforms. Zimmer has a one-stage implant called the Advent that's quite similar to the MIS Mistral that I just showed you. And again, Straumann also has their tissue-level implant, again, quite similar. My preference personally is the Mistral. This is a typical case of what we'll be discussing a little more today, of how we are treating many of our full arch cases. And you'll notice that in the maxilla, we don't have a bar, which traditionally some people have felt needed to be done on a routine basis. So this is a very common type of case where in the mandible we'll place at least 2 implants. We say 2 is good, 3 is better, 4 is best for these full arch overdenture cases. And this would be a very common prosthetic solution for a full arch maxilla when we've decided on a removable overdenture restoration. And that's what a typical prosthesis for the maxillary overdenture can look like. And you'll notice there's a metal reinforcement there as well. And we will come back to that when we look at problems and fracturing of the prosthesis when you don't have this metal reinforcement. But looking at, again, an overview of cases, we certainly have done 2 implant cases and various different types of attachments. We'll discuss in this webinar, would we consider 3? Is 3 better than 2? And if so, why? Should we be considering bars for our overdenture cases, be it in the mandible or the maxilla? How many implants with a bar? Does it make sense to have more than 2? Should we have 3? Does this design make sense with a midline implant? We'll come back to all of this. How many implants do we need if we're doing an overdenture or a bar overdenture? Do we need 2, 3, 4, or 5 as in this case? Do we need 6? Is this distribution correct for an overdenture design? Again, this is an overview. We're going to look at all of these questions in more detail as we move along. Here is a bar overdenture in the maxilla that's milled, and on the milled bar there are some locators placed. Is there a place for this type of design? What are the pros and cons? Another whole area that I feel is really undertreated are partial arch overdentures. And I think this is a tremendous area where we can really help patients to improve retention on Kennedy Class 1 or Class 2 free and saddle situations, get rid of those unsightly clasps. It's something that I think a lot of us don't think about, but it can be an excellent treatment. And you can see here an example of one of my cases where we did this bilaterally. And even with the pneumatized sinus and these implants placed somewhat anteriorly, clinically the results are routinely excellent. This is a case where we actually have extremely thin bone in the orofacial dimension, and if these patients are unwilling to have bone grafts, there are some cases that you might suggest mini implants of typically 2.5 millimeters in diameter, perhaps all the way as narrow as 1.8. Again, this is in my practice, not my first line of treatment, but we do some mini implants in the appropriate cases, so we'll discuss that more as well. And you see that case here. Even using mini implants for partially edentulous patients for partial overdentures is also something that can work quite nicely. Again, when the bone is compromised and patients are not willing to have the bone grafting done. And perhaps in some cases we wouldn't even look at the bone grafting as perhaps our first line of treatment. Maybe simplifying the treatment with mini implants in a case like this is an excellent option. Let's backtrack a little bit before we delve into more detail on the cases, and let's just again ask ourselves, is the treatment we're looking at here in this webinar, is it evidence-based, and what are the risk factors when we have failures? And the most basic question that you've heard ad nauseum through many presenters, and is, do osseo-integrated implants actually work? What is the long-term predictability? And the reason I pose this very basic question is I believe we have to have an attitude of healthy skepticism when we look at the literature. I think even in peer-reviewed journals, there's definitely a place to try to root out bias, and I think we all can have potential for bias. So I also want to include my own personal clinical statistics, because I do keep track of everything on a computer system, and I'm going to share that with you now. In my own practice, as of earlier this year, we've got now over 12,000 implants, everyone being followed on a sophisticated computer system. In terms of survival rate, overall, we have about a 95% survival rate, and there's hundreds of risk factors we could break down these statistics in, but if we just compare good bone, what I call B3, compared to poor bone, which I can call D4, we can see that we can have a substantial difference in the survival rate. Again, just plucking out one of hundreds of different attributes, we could look, if we look strictly at Straumann implants of different length, and I published this article in JOMI in 2009, I believe it was, maybe 2006 actually, where we showed pretty good survival rates for 6mm implants. As an aside, I'll tell you, 15 years later, we've dropped below 90% on the 6mm length implants, but that's the subject perhaps for another webinar. But back to overdentures, in the mandible, there's been numerous publications showing very high survival rates, and I don't think there's any argument there. But when we look at maxillary overdentures, and in particular unsplinted maxillary overdentures, there's very few publications, perhaps because traditionally implants in the maxilla for overdentures were often splinted with a bar. Again, traditionally, the original Brannemark implant showed very high failure rates with the maxillary implants in poor quality bone where the implants were short. Again, this is my own statistics, and you can see that with almost 2,000 implants utilized for unsplinted overdentures, and over 300 of those being in the maxilla, you can see that we do have a very respectable survival rate. So at least in my own practice, I found that this is a good treatment. Maxillary unsplinted overdentures. And Tarnow and others have published on case reports, but there's very little in the literature, and certainly nothing published with the over 300 implants, so I should be publishing this. So again, moving on to surgical risk factors, and this is not within the scope of this webinar to discuss all the surgical factors related to implant survival, whether it's overdentures or any prosthetic application, but it's worth just mentioning that this two-day lecture that I sometimes give, we can divide contributing etiology to failures as host factors and non-host factors, and you can see the subdivisions within those two. Host factors, subdivision systemic factor, for example, could be uncontrolled diabetes. Host factor, a local factor, could be poor quality bone. So when we look at these different categories of etiology for implant failure, the same four categories are highlighted in yellow here. And of course, within those categories, there are many more drop-down menus or subdivisions. And as I say, it's not within the scope to discuss that here, but suffice to say that I find in my practice the overdenture restorations and implant survival rates are very comparable to other prosthetic designs, including the maxillary unsplinted cases. So let's go back to some basics with consequences of tooth loss. In the maxilla, the bone resorbs up and in the mandible inferiorly and facially, so patients will get a class 3 type of jaw relationship. And this goes back to our basic courses in denture therapy, where we know anatomic consequences of tooth loss include bone loss, prominent bony ridges, increase in size of the tongue for the fully edentulous mandible, thinning of the tissue, forward movement of the denture, complete lower denture mobility and function being much worse most times than the full upper denture, and in some cases exposure to the mental nerve in the mandibular posterior area. Related to this, the aesthetic consequences of tooth loss can again be protrusion of the lower jaw, getting that class 3 profile, collapse of the vertical height of the face such that the chin and nose approximate, sagging of muscles and loss of muscle tone, increased length of the upper lip, deepening of grooves in the skin over the lips, less clinical crown showing at rest position, and basically a lower or high lip line with the age smile. Specific to the lower jaw, if the patient is having symptoms, we need to find out, is it just looseness or are they having pain? Perhaps the mental nerves are being impinged upon. We have to assess the vertical dimension, occlusal plane, interarch skeletal jaw relationships, interarch clearance, and in determining the number of implants we want, we have to determine if the patient can tolerate some movement of the denture, where we might just use 2 implants, or maybe we'll need more than 2 if they cannot tolerate movement. Now this gets to the meat and potatoes of comparing fixed versus overdentures, and there are some obvious pros and cons. The removable in my Toronto practice costs less than half of what a fixed prosthesis would cost. The surgical placement of implants is somewhat less demanding, and complications more common with some of the published studies. A lot of these are very minor complications like tightening a clip or replacing an attachment for an overdenture. Compared to fixed, which can be double or triple the cost, and there can be more support, and for some people it's very important because fixed feels more like their natural teeth. But if we lose a strategic implant, mitigating that problem can be extremely difficult and expensive. Here's a recent full arch fixed case, and the prosthodontist filled in all the missing hard and soft tissues with pink porcelain. And you could imagine that this patient does have some hygiene challenges for sure. A different type of case with the patients with very poor oral hygiene, where hygiene access is there if the patient was willing to do the cleaning, but there can be other challenges here related to aesthetics, phonetics, lack of lip support. So with looking at full arch fixed restorations, we have often these challenges, and as well, often we don't have enough available bone such that we need patients who are willing to undergo extensive bone augmentation. They need to be prepared to pay the extra cost and to accept perhaps compromises in dealing with significant ridge resorption by having a combination of longer teeth and or prosthetic gingiva and or large spaces being left for hygiene access, because aesthetics, phonetics, and hygiene are typically more challenging. And as I said before, it's worth mentioning again, if you get an implant failure of a strategic implant in a fixed case, it can be very complex to try to fix. So overdentures can be an alternative to fixed, sometimes just a stepping stone to fixed. But the patient has to be willing to accept a removable prosthesis. In my office, some patients come in with a preconceived notion they want fixed. We give them informed consent to all available treatments. They often leave wanting the removable once they know what fixed really means. And of course, if we have a case where we can't even place 4 implants, or we need to use mini implants, or the hygiene, phonetics, and aesthetic requirements or the financial considerations are such that fixed is just not possible, then overdentures can offer an excellent alternative. Particularly in the maxilla, if we have extensive bone loss, and the things I've listed here, which is repetitive to some degree, in the maxilla especially, the fixed cases can be very challenging. Contraindications for an overdenture that's tissue supported, for example, just 2 implants in the anterior mandible, is if the patient has the posterior phalanges already impinging on the exposed mental nerve. And that would be the main one where we would need a different design and more than 2 implants. Implants of less than 8 millimeters in length, perhaps. Poor bone quality, perhaps. This is less so than it was years ago with the original machined implant. Now, it's not just me saying that aesthetics and phonetics and hygiene access is often difficult with a maxillary fixed prosthesis. This is just a systematic review, and it's one of the references in there that basically says the same thing. They also say, and we'll come to this, that if we have a maxillary case with very compromised bone, we might want to consider 6 implants instead of 4. So as we look now at actual cases, we are going to look at some fixed cases and failures and how we can deal with them, and of course removable overdentures, and we're going to look at dealing with complications as well. So just very briefly, we have many different categories of full arch fixed restorations. If we look at the mandible and a crown and bridge design with 4 implants, where all the implants have to be placed anterior to the mental foramen, in many cases we can have a very nice fixed restoration. This is more commonly achieved without complications in the mandible compared to the maxilla. And if we're fortunate enough that we can fit in additional implants posterior to the mental foramen, where we have sufficient height of bone over the inferior alveolar nerve, we can provide the patient with a more complete dentition, larger number of prosthetic teeth, such as in the case you see here. And again, it doesn't always have to be a crown and bridge type restoration. University of Toronto developed the so-called hybrid restoration, or the University of Toronto type restoration, where we can have what can be a chrome cobalt framework with acrylic gingiva and teeth attached to it. Here again, we have a case where we were able to fit 2 additional short implants distal to the mental foramen. Some people call this a high water design, and it still can be an excellent restoration. And here's the occlusal view of that last restoration that's been in the mouth now for over 20 years. But getting back to some of the challenges with fixed restorations, what often happens, and I'll show you this case again of a full arch fixed restoration that looks somewhat similar to the last one, but when you look at the occlusal view, you can see that the implants could not be placed close to where the prosthetic positioning of the teeth had to be. So this patient has a huge ridge lap that will be very, very challenging for them to try to clean. And it happens in the mandible and even more so in the maxilla. So when we're looking at the fixed, fully edentulous maxilla, we need to ask ourselves, how many implants, where are they positioned? Will it be a crown and bridge design? Will it be an acrylic hybrid? And of all the things I've listed here, the most important one that we've alluded to and we're beating to death here, how do we deal with significant ridge resorption? Combination of longer teeth, prosthetic gingiva spaces, or one at least of those 3. Let's look at a crown and bridge type case, and here's an example where longer teeth were utilized to basically, I'll use the term bridge the gap, to make up for all of the hard and soft tissue resorption. And for some people this can work, i.e. they have a low smile line and these long teeth are not in the aesthetic zone. And we looked at this case before, and that's the one with all this pink porcelain. This can satisfy aesthetic and phonetic requirements, but hygiene is a challenge. And we looked at this case too, where the spaces are there, but this can cause challenges with aesthetics and phonetics. Well, one solution can be, and this is a joke, party gums, but it can work. Here's a patient with the party gums out, and there's how it looks with the party gums in. So a removable acrylic gingival veneer that just snaps into the undercuts of the teeth. Not what I'm suggesting as a mainstream form of treatment, but something that might bail you out on a difficult case. And again, full arch maxillary implant restorations that are more acrylic or a hybrid type design. Here's a case. And this is again on the model, typically what we're dealing with and what it can look like clinically. Again, the issues we brought up before. Something we alluded to before was that with a fixed case, the 3-dimensional positioning of the implant can be more critical. And this is a problem that needs to be dealt with, that if you don't have the vertical dimension to deal with angulated abutments, you may have to restore these access openings. So it can be more tricky. With fixed with an overdenture, typically you have more room to work with and you don't have to deal with this. In this particular case, we do have a fairly high lip line, and so we need some aesthetic restorations to plug up those access openings. Of course, we have cases where we do full arch fixed in the maxilla and the mandible, for example, a crown and bridge type of application. Again, same as we discussed before, this case has less severe resorption than some of the previous ones, but still the teeth are certainly longer than ideal. And same idea with both arches with the acrylic type restoration. Again, it can work, but there are challenges. How about cantilevering off these fixed restorations? We do have some clinical guidelines, although it's not an exact science. And many of you will remember Dr. Charles English, who was credited with developing some clinical guidelines for the anterior-posterior rule, where depending on the AP spread of the implants, you could cantilever 1 to 1.5 times the anterior-posterior spread of your implants. Just an additional comment on that. Well, here comes the interesting part. How do we deal with failures with the fixed cases? This is my father's case. 3 implants placed, and after about 8 years, for some unknown reason, the middle implant started failing badly. Progressive bone loss with lots of suppuration, as you can see here, and a deep pocket. Fortunately, we could convert that middle implant to a Pontic, and this was one of the very few cases where we could easily deal with this type of problem. But this is a more typical situation where on the patient's lower right, they are having progressive bone loss, and we will have to remove that implant, and it is a strategic implant. If the patient is unwilling to allow us to replace that implant, we have to make a whole new prosthetic design. So as you can imagine, the patient has gone through a lot to get a fixed case, and in this case, about 8 years later, has to have a new prosthesis made, and it isn't fixed anymore. This is a different type of case where we had 2 implant fractures, hex splits, with a particular implant design before 1995 that was prone to this. It used to be a full arch fixed case. Similarly, we had to convert the patient to an overdenture case because they were not willing to allow us to redo those 2 broken implants. Let's now look at some cases of removable overdentures in more detail, and also look at some complications and failures in dealing with the overdentures. Now, to go back to the very beginning when we had some definitions, once again it's worth emphasizing what kind of implant design is best for an overdenture. And I would suggest that you use a one-stage implant design where the prosthetic platform can be positioned at or even supragingivally. I mentioned my preference for this. It happens to be the MIS Mistral implant, which is prosthetically basically a clone of the Straumann tissue level implant, with the smooth collar being positioned above the bone at the time of surgery, and that's about 1.8 millimeters in height. And this is just showing you a surgical slide with these implants partially inserted with some pre-attached fixture mounts that can also be impression copings. And one of the things I like about this system is they have an insertion tool that if you already are at 50 Newton centimeters and you need a good strong torquing device to just seat the implants a little further, this can be done quite easily, unlike another clone, another system that the name I won't mention. So here are our Mistral implants fully seated, and we can place a lower profile cover screw or a 3 millimeter healing abutment. Here the 3 millimeter healing abutments are attached and the area sutured. So that is again a one-stage implant design, and it is a one-stage surgical protocol where after this typically local anesthetic and is not needed and there's no pain. So after a bit of healing, when the healing abutments are removed, this is the restorative picture, and you can imagine how easy it is to work in this kind of supragingival environment, which is fine for an overdenture case. And here is a case of 4 mistrals, typical kind of placement, anterior to the mental foramen. We've got more bone to work with than in many of our other cases. And here again, clinically, locators are very popular these days. And this is how we treat a lot of our edentulous mandibles. But you notice there were 4 implants there. The question is, how many do we really need? Again, the McGill consensus statement said that for a patient with a complete lower denture, the minimum standard of care is 2 implants. And in the maxilla, although there's no publication on it, for a standard of care, many clinicians will agree a minimum of 4 and even sometimes 6 implants if the maxillary bone is compromised. So at least clinical guidelines for myself, in the mandible, 2 or more. 2 is good, 3 is better, 4 is better still, although there have been some studies done with 1 implant in the mandible. And in the maxilla, 4 and even more if the bone is significantly compromised. What about the positioning of the implants? And again, let's look at unsplinted cases. In the mandible, if we're doing 2 or more implants and they're unsplinted, whenever you're dealing with unsplinted implants, implant parallelism is actually more important than if you're dealing with a bar. So we need to take our time during surgery to try to get these reasonably parallel. And that's because the path of insertion needs to be, reasonably parallel. Or else you'll wear out your components or maybe can't even seat the prosthesis. If you're doing a bar, you can create your path of insertion through the fabrication of the bar itself. So this is a case that's been in the mouth for over 20 years with a ball type attachment. Here's another case where we are off angle. I'd like to say it's not my own case, but it is, again, done about 15 years ago. And again, you may tend to get more wear of the attachments if you don't have a parallel path of insertion. So where should we position our implants if we're only doing a 2-implant overdenture? And I think most people will agree we typically want to place it at the cuspid positions. This happens to be a Nobel replace tri-channel type design. And that can work very nicely as long as the patient is aware what they're getting. Now, in this case, we've positioned the implants at the lateral positions. And I want you to think for a moment, why would we do that? I think we have a second case, again, where the implants are positioned more anteriorly. And look at that prosthesis. Well, the reason we do this sometimes is when a patient indicates that in the future there's a reasonable chance they may want to add 2 more implants, we don't want to put the implants in the cuspid positions because then we cannot comfortably space out 2 additional implants if we have to stay anterior to the mental foramen. So this can work quite well. Now, when we only use 2 implants, unsplinted, in the mandible, and especially if they're short implants, do we really know that they're going to last a long time? I mean, most published studies, you're very lucky if you can find a 10-year study. So again, going back to my own clinical experience, because our own clinical experience is an important piece of what we call evidence-based therapy. This case is 18 years old. There's the radiographs. That would be what's called a stereos implant. This patient came back to me after 6 months of treatment. I maybe should have mentioned at the beginning, as a periodontist, I don't do the definitive restorative work, and it's sometimes hard to get patients to come back. So this patient came back not realizing that implants need to be brushed. He thought they're not teeth, so they don't have to be brushed. Just chairside, we quickly remove some of the plaque and calculus, but this patient did come back for periodic checkups, and despite that difficult start, is still going very strong even after 22 years. Here are other cases. These are 8mm implants. These happen to be the screw vent design. Again, very challenging cases, not the best home care, not the best keratinized tissue. We've got many, many cases like this that I think will go on indefinitely for the patient's lifetime. So that was 2 implants. What about in the mandible if we're going to use 3 implants? And again, we're looking at unsplinted right now. So where would we want to position them? And is 3 implants better than 2? And this is diagrammatically where we might consider placing 3 implants. And I believe that there is an advantage to this tripod effect with less denture rotation compared to just 2 implants. Again, this is not a completely implant-supported prosthesis. It is implant-retained, but there's less rocking motion, and clinically we find 2 is good, 3 is better. Again, another case where we were fortunately able to get a pretty good AP spread. Many patients don't want 4 implants for economic reasons. Now, how far apart can we space these? We're often confronted with this decision where if we want to spread the 2 distal implants distal to the mental foramen, in most cases we have to choose a shorter implant. I think that in many cases it's not worth going to a very short implant just to improve the AP spread for unsplinted overdentures that are strictly supported. I would rather have a longer implant mesial to the mental foramen. But case like this, we don't have a choice, as in many cases where there's just not enough bone over the inferior alveolar nerve when you go distal to the mental foramen. So most of our cases end up being more the anterior distribution. And frankly, for these patients who are coming from a complete lower denture, often for many years, really appreciate the improvement. And in many very severely resorbed cases, the implants even have to be placed closer together, but clinically these patients are extremely pleased with their results. Notice these last 2 cases did not have metal reinforced mesh, which I would recommend. So we try to spread them out as far distally as we could go, but again, for these types of cases, the anterior distribution works extremely well, and these last few cases have been more of these Mistral type cases with locators on them. Now, how about 4 unsplinted implants? And again, the same issues as before. On occasion, we can get a decent size implant distal to the mental foramen, and when we can, we'll do it. It's nice to have this big AP spread. It just gives the patient that much more stability. But it's not too often that we could do this, but we can. And more often, we're staying anterior to the mental foramen with routinely excellent results in patient satisfaction, even when we don't have as wide a mesiodistal spread of the implants as we can have in some cases. Now, what kind of attachments should we consider for an overdenture case? And again, I am not a restorative dentist. I can tell you that the vast majority of overdenture unsplinted cases being done today are being restored with locators. Locators are made to fit on all the popular implant systems, such as the Nobel BioCare tri-channel. And this is actually what's called a TC design. This Nobel design has a 3mm smooth collar designed to be more of a one-stage implant. Many people don't even know about this implant. Here again is the Mistral design that we've been showing many cases of, and again, locators. The Mistral design is the Sin Octa type attachment, the same as the Straumann tissue level design. These are Zimmer Advent implants, which actually have an internal hex connection specific to this design. It's different than their screw vent hex size, but they can receive balls or locators similar to the other systems. This is a bit of an older case, standing up well. This is a case, I don't know what kind of attachments these are. This was a patient who wanted the lowest possible cost. They've stood up for 23 years now, and again, the prosthetic design is not fancy, but it worked for this patient, so sometimes you never know. Back to locators, which we're almost seeing routinely. How high should the locator be? Again, I'm not a restorative dentist, but I'm told a millimeter to 2 millimeters, maybe 1.5 above the tissue. So these are too tall. Remember, the locator is only supposed to connect at the top part. the side walls of the locator are not meant to engage the prosthesis. So the taller they are, the more likely you cannot seat the prosthesis. So these are cases I've just shown you for interest purposes where the restorative dentist is not following the protocol and the locators are much too long. This is a one-piece design with the locator being attached directly to the implant, and it's an implant direct design called the Go Direct. And I have used several of these, and they can work well. And this is the implant at the time of placement. Again, this locator is part of the implant itself. And those of you who will think ahead will realize the disadvantage here is you are dealing with the locator height that the surgeon provides you. And there's little to no ability to change the height of the locator. And this is the big disadvantage of any one-piece implant. You do not have prosthetic flexibility in the abutment that you choose. These are just little protective caps, and here's that case after some healing. Let's talk about maxillary overdentures now, and again we like to have at least 4, and we'll talk about unsplinted implants and look at where should they be positioned, what kind of attachments. Is this a design that can stand up to stress, and are we going to see more bone loss and more failures? Well, let me remind you of a slide I showed you before, and the middle bar shows over 300 maxillary unsplinted implants with a survival rate of almost 97%. You won't find this in the published literature, and it tells me clinically very strongly that this design does work. And again, to show you once again a previous study, that when we're dealing with compromised bone, perhaps we would consider 6 implants for a maxillary full arch overdenture case. Here our bone was quite good. We were able to get good size implants in, and this is a case I'd be extremely confident would be successful for the patient's lifetime. And here's clinically what a typical case can look like. And again, just the facial view, same idea. Again, this prosthesis should be reinforced, but very low stress demand with 4 strong implants like this. Sometimes we will go to 6 implants, as you can see in this case here. And when we can, even if we're just doing 4 implants, whenever we can, we spread them out with the best AP spread possible. But more often with pneumatized sinuses, this is sometimes the best we can do. And again, clinically, I can tell you that the patients are very satisfied with this, and they have good retention and part of the palate removed. And it's obvious to see here how hygiene will not be an issue. Sometimes in really small maxillas, the implants are closer together, but even these cases we routinely find patients are extremely pleased. And you could see this latter case, the maxilla and the mandible. Well, let's look at a full case, and I'll show you some of the laboratory procedures for a maxillary and mandibular overdenture case. We did full mouth extractions here. We chose not to do immediate placement. We let things heal for several months, and with use of an implant placement guide, but not a computer-based guide. I don't use computer-based guides for these overdenture cases because I don't feel you need that precision. So here you can see we placed 6 implants in the top, 4 in the bottom. We can see this is a 1-stage surgical protocol. This is after a period of several weeks of healing in the maxilla. Here's the mandible. Again, these are the Mistral implants with the 3mm healing collars. Now, these slides were taken by the restorative team, custom tray, and they did do implant level impressions. Actually, I think these are locator level impressions. So it's easy for them to eyeball what height locator they're going to need, because they know from my letter or they can see the height of the healing abutments, so they know where the prosthetic table is. If they want the implant to be 1.5 millimeters supergingival, it's very easy for them to select that. So then they're doing impressions, as you can see. I'll go through this quickly. Impression is removed, analogs are seated, and now the impressions will be poured up. Interesting palatal design, which we don't have to discuss. It's not within the scope of this webinar, but you can see the master models. You can see the reinforced mesh that I do strongly recommend for all of these cases. And your typical setup with bite blocks for the same like you would do for a denture setup, going through all the steps, and eventually the final prosthesis with the 4 in the bottom, and in this case 6 in the top. And here's how the case looks clinically after it's finished: 4 in the bottom, 6 in the top. Very nice case, and again, as long as the patient psychologically will accept the removable type design, this can solve a lot of problems that we can encounter with fixed cases. And here's the final radiograph with the locators in place. So failures, that's always the interesting part, and we have failures with overdentures, but keep in mind, we don't have many failures. Our success rates are high, but let's dwell on those few percentage points of failures. And again, if we look to some publication by Slot co-workers, they do discuss that prosthesis survival, even if it's not analyzed, there's a discussion at least of the advantages of unsplinted case designs related to the survival. And if you have a failed implant that you need to replace, they say it's easier retrograde prosthetic fitting of a replace failed implants. That's huge. So when we look at failures, we can categorize them. Let's look at the first category, where the prosthesis itself has a superstructure failure, and here's one of those non-reinforced ones, and they'll often fail at the weakest point, as you can see. So it's worth spending the extra $175, whatever the lap cost is, when you look at the overall cost of the case and put in one of these designs with the reinforcement. Sometimes we'll get a bar overdenture where we'll actually get the bar fracturing. As you can see on the patient's left, that fractured off, and we ended up adding an implant with a separate locator. Just a simple way to fix that case up. So sometimes we have implant failures where we do need to replace the implant. Again, a similar case like you just saw before, where the bar had to be cut short and the patient felt she didn't have enough retention. So we replaced the failed implant, but we didn't redo the bar on the other 3. We could have, but this was a less expensive way to get her back on track with her prosthesis. This is, again, one of these TC implants that's being removed because it's failed to integrate. It is a strategic area, being the distal implant in the arch. And again, we can do a similar thing as we've done in the previous case, where if we replace that implant, we don't necessarily have to redo the bar if it is restored with a bar, like the previous case. Now, these implants on the lower have a highly textured surface. I did not place them. Some of you are familiar with the Innova implant, or locally here, there's something called a 10X implant, which copies the Innova. These surfaces are 10 times more rough than what you'd normally find, and they can be prone to peri-implantitis. Anyway, one was lost, so obviously in this case, well, maybe not obvious to everybody, but the patient needed more implants. So we left the middle one, which is failing as well, and we just added 2 Mistrals, as you can see. So obviously a case where patient was happier having now 3 implants in the mandible instead of just 1. And there's the prosthesis. Now, I mentioned that I feel that the partially edentulous cases are overlooked quite often and can be helped out tremendously with implants, but we're talking about problems and failures. So what happened here? Here you see what looks a very nice solution to prevent an unsightly clasp on the patient's central incisor. But the implant that was used was too narrow, and you can see the distal one fractured. Now that one fractured, I told the patient she's at risk, even maybe higher risk of the other one fracturing. So I strongly recommended that we put 2 additional implants in. Here's that fractured implant. Here's the pan. You get the idea. Let's look at when we have an implant failure that's not terribly strategic and we might not have to replace it. This is a patient who originally had 4 implants. They lost the middle one, but they're actually functioning very well on the 3. Really not interested in replacing it. So in this case, we could get away without that, even though that's not how we would ideally like it designed. This has been functioning in this manner for over 15 years. So we do what works for the individual patient. So here's a 4 implant case, unsplinted, and we've lost what I'll call a non-strategic implant. And like the previous case, we offer to redo the implant on no charge to the patient, but very often they're functioning so well that they're just not interested in going through the replacement, despite the fact that there's no cost to them. Another case, same idea. We've lost the implant at the lower left lateral position, and the patient's functioning well. Here's another case, and same idea. So same theme over and over. We'll replace it if the patient wants, and very often they say they don't. This case, however, this is a BioHorizon case. We did lose the lower right distal implant, and this would be more of a strategic position. And again, in some cases, even here, the patient will not want to replace it. But more often with these kind of losses in strategic positions, we are replacing them. And then there are other cases where, again, no replacement is needed. Let's look first at unsplinted cases where we've lost one in the lower right, but we still have one to the distal, so it's even less important here. And this patient can function extremely well without replacing that implant at the lower left bicuspid area. What about if the implants are splinted? Are there cases where, with a bar, for example, where we lose an implant, where the patient's going to lose the upper right distal implant due to progressive bone loss, but we salvaged the bar and we just created a cantilever design. We felt that biomechanically this we could depend on, and again keep the patient's treatment quite simple. This patient on the lower right will lose the lower right second to last implant. Don't ask me why this was restored with a little bar there. So we're going to remove the lower right second to last implant, and we're going to put a locator attachment on the remaining distal implant and retrofit the prosthesis to that. You can see us using what I call the implant removal tool. This one is from Zimmer. You just rotate it counterclockwise, and you can see we've removed the middle implant, and you get a hint on the distal implant that remains. We've now put a locator attachment and retrofit patient's existing prosthesis to that, and you can see here the attachment inside the prosthesis. Now, bar overdentures, at least compared to unsplinted cases, do have higher cost, more difficult hygiene, gingival hyperplasia, more technically demanding, more vertical dimension is needed, and could be more difficulty and costly if there is a failure. So we have pretty much stopped doing bar overdentures even in the maxilla, as you've seen previously in this presentation, because we would almost routinely see this kind of gingival hyperplasia. And this has been reported in the literature as well. It's not just my practice. And other studies have shown that unsplinted attachments were easier to clean and harbored less plaque. So if we have 2 implants in the mandible and they're positioned at the cuspid, in the past some of our restorative colleagues would like to use a bar, but I don't think that that's necessary. Nevertheless, we've seen different bar designs over time. If we've done 3 implants, does it make sense to make a bar that is not going to allow rotation of the clips at right angles to the axis of rotation? No, to me this makes no sense at all. So this type of design to me is counterintuitive to what I was taught. Here's a bar with separate attachments that are fabricated onto the bar itself. Not a bad design, but again, is it worth the extra cost to make this design as opposed to 3 unsplinted implants? You can make that final decision. If we're looking at 4 implants splinted together, again, a very elegant design, but clinically, patients, do they gain enough to warrant the extra cost and complexity of going from unsplinted implants to this type of bar design. We used to do this a lot, and we rarely do it today. Milled bars, you can get more and more costly and sophisticated. They're not bad restorations. We have to balance the cost, complexity versus the clinical benefit. We can go with more than 4 implants. How many do you need? Here's 5 with a similar design. We can go with 6, but again, do we really need to do this? Are we really doing the patient a service? In this case was originally going to be fixed, and then after the implants were placed, the patient changed their mind. So the distribution of these implants is very poor for an implant-supported overdenture because it won't allow rotation around the long axis. So in this case, you probably have enough implant support that perhaps it be very retentive and supportive and won't make a difference. So an unusual design because of a change in the prosthetic treatment plan. So as we said, the bar overdentures compared to unsplinted, we looked at all of these things that the title slide before. And again, looking to the maxilla, sometimes in the past, we've done 4 with the bar, similar design as we saw the mandibular cases just before. Again, more than 4 implants. This is a Straumann case. Nice cantilevered bar. Again, it's certainly a good restoration. 6 implants, broken in the center. Again, all of these designs work. The question we ask ourselves today is, can we get equivalent satisfaction or almost equivalent satisfaction, keeping it simpler, less expensive, easier to clean than these types of very sophisticated bars, and in this case a milled bar. And again, you've seen other designs with little pins that lock these in place, Marius type of restoration. So there's no limit how sophisticated you can get. This case was supposed to be a fixed case, and the bone was very compromised. If you want to do a bar here, there's no room for a midline clip, and we saw that other 6 implant case in the mandible that also was supposed to be fixed. So when we know we're doing a bar overdenture, we want to leave enough room in the midline to put a clip. In this case, there was no choice but to do a milled bar because there was not enough room for a clip. So the retention was achieved through the frictional fit to the milled bar because there was no clip possible in this case. And again, partial arch overdentures, which we talked about. Here is a case with a remaining cuspid that's quite strong, and the patient only wants 2 abutment teeth. And what's wrong with this? If that cuspid has a good long-term prognosis, it's only implant supported anyway. So I feel that this is a reasonable treatment. Sometimes we have difficulty finding bone to fit in any implants, and the patient doesn't want bone grafting. And even though this is not symmetrical, this does the job in terms of helping the patient have a more retentive partial overdenture prosthesis. And they can work beautifully, something that, as I mentioned, undertreated. And we looked at this case before. We need to use strong implants. I like the Mistral MIS. The MIS system has titanium alloy, which when you go to the narrow diameters, I feel is helpful. Here's one of these cases where we're going to do a partial arch restoration with 2 of the Mistral implants. And then the patient decided she wanted fixed. Well, we had no problem feeling confident we could cantilever off of these 2 very strong implants and ended up doing a fixed restoration. Showed you this case before. Here's the other side. This has been in place now actually for well over 10 years, actually about 18 years, and holding up beautifully. Again, partial arch. We can use little bars instead of individual unsplinted attachments, as you see here. And there's the prosthesis. Here a bar was done, I believe, because there was inadequate vertical space for at the implants, and you could see there's a distal extension. Although today I would recommend we do 2 unsplinted locators. But this is how the restorative dentist designed this, again, about 15 years ago. So last point on our outline is, again, to revisit mini implants for overdentures. And in the beginning of our webinar, in the overview, we touched upon this. Let's talk about this a little more. Mini implants, for the most part, tend to be one-piece implants. And we need to be a little bit more cautious with mini implants because they haven't been around as long. We need to ask ourselves, what is the success rate and long-term success rate? What is the fracture risk? If we are doing mini implants for fixed cases, there are issues with emergence profile, ridge lapse, aesthetics. And the surgical placement of the mini implant, sometimes it is hard to get good initial stability. And positioning is critical because if it's a one-piece design, the abutment is pre-attached to the implant and there's no customized abutment possible for the restorative dentist. So again, if we look at one-piece implants, again, we have all these disadvantages. We typically cannot submerge the implant if the initial stability is poor. There's only so much modification you can do to some of these mini implants. So if your implant is not in an acceptable position, it cannot be restored. It has to be removed. If the abutment wears, if it's a one-piece implant, you cannot replace it. A lot of companies have very limited components for indirect fabrication. And sometimes because of that, we find the accuracy of the fit of the prosthesis, especially in these fixed cases, is not great. At least that's been my clinical experience. I mentioned the Implant Direct and the Go Direct, which has the locator attached to the implant. The narrower is 3.0 millimeters. They have a 3.75 as well. And again, you can see how the locator is part of the implant. And again, they can work, but again, the surgeon has to get the height of the locator accurately done at the time of surgery. But they can work. And here's that particular case. Here again is the Go Direct for a 4-implant complete lower denture case. Same idea. We've got to be a little extra careful, do the best we can to make sure that upon complete soft tissue maturation, that those abutments are at the correct height. This is another design from BioHorizon, the 3.0 one-piece. They have ball attachments pre-attached to the implant as opposed to locators, and they are 3.0 as well. And again, same challenges, but placed properly, they can be effective implants. Here's another case where we have extremely narrow ridges posteriorly. Patient wants a posterior implant placement for a partial overdenture. And you can see we have very minimal bone width to work with, of just about 4 millimeters. So we are going to use the mini implant design for a partial overdenture design with 2 implants bilaterally in the posterior mandible. The posterior implant there is only 1.8 millimeters in diameter. But this case actually worked out extremely well. Here's another case where we're going to remove the remaining teeth, and all of these patients have been given all their options, decline bone grafting. We were able to fit 2 3.5 millimeter diameter implants posteriorly. Anteriorly, even the 1.8 millimeter implants could barely fit in the ridge. We even have a small crack in the bone in the middle implant. So this will be a combination of 3 mini implants and 2 3.5 millimeter implants. But this case worked out quite well. Not your routine type of case, but sometimes if the patient's unwilling to do the bone graft and the larger diameter implant, this gets you out of trouble. We looked briefly in the introduction at this maxillary case where, again, with the CT scan, you could see the bone we're dealing with. Once again, the patient has declined bone grafting, and we're going to treat this full maxillary arch by placing 8 implants. And you can see the healing, and we soft tissue reline to help prevent transmucosal loading as much as possible. And this case did work out quite well. So we've covered about 400 slides in less than an hour and a half. and I've gone at a very quick pace. In summary, we do offer patients all the options. We give them informed consent so they're not misled, that they know what they're getting in the final result, in particular the pros and cons of the various different prosthetic types. In our practice with the full arches, and especially in the maxilla, we are doing a lot of overdenture cases, and in general we've gone away from the bars and are having extremely good success in the unsplinted type design, both in the mandible and the maxilla. It's a tremendous advantages, and I hope that you will keep that option in mind as you have your consultations with your patients. So once again, I want to thank you. I want to thank Dental XP for giving me the opportunity to do this webinar. I want to thank you for participating in this webinar, and you see my website that if you have any questions, you can find my contact information through my website, and you can see many presentations I have on there as well. Thank you once again. Goodbye.